Thank you all for having me this evening. First and foremost, I am going to try to share slides. We are in Zoom technology world, right? So anything can happen, and I've just subscribed to if it can happen, it will. But give me just a second to see if this will come up. And I think it did. Awesome. Thank you for that great introduction. And again, my name is Tekisha Dwan, Everette, Executive Director of Health Equity Solutions. And starting with the commercial break of who we are, we're a nonprofit organization located in the capital city of Hartford. But we have a statewide focus on ensuring that every Connecticut resident has what they need to attain their optimal health, regardless of their race, ethnicity, or socioeconomic status that exists within the state of Connecticut. Generally, we do this by promoting policies, programs, and practices that result in the equitable healthcare access, delivery of healthcare, and outcomes for anyone who made their way and find themselves in Connecticut. That's our goal and where we start. I want to start by saying we focus primarily and fully on racial and ethnic minoritized individuals within the state of Connecticut, and we are unapologetic about being an anti-racist, race-forward organization. Our work and what motivates us is our theory of change, and this is my opportunity to just say how these things work together and how we get to the work. We do believe that education is critical. So many individuals are not aware, and this isn't just what I would like to call routine education. This is the point about exposing inequity in the root of it and making it clear why the inequities we see that exist in Connecticut exist, and how we take that awareness and move that into action. And the action points are agitation and advocacy. Ultimately, we try to leave quite honestly, we try to leave everybody uncomfortable at the end of every conversation, and hopefully feeling the need to do something with that discomfort, which we try to move people into advocacy, whether that is with us or on their own in work that we support. Ultimately, we hope that all of this leads us to health equity, to optimal health, access to care, quality of care, and reduction of disparities. Tonight, we're talking about the social determinants of health, race, and racism. And I just want to start by talking about health equity first to give a frame, and then moving into what I mean by race, into social determinants of health, race, and racism. So health equity is the opportunity for everyone to have fair and just opportunity to attain their optimal health. And at the beginning, Fawati showed a different version of the same images around the difference between equality and equity. I'm not going to go deep into these. Each image that could be put forward is fraught with a lot of critique, but ultimately what I want to highlight in this image is that when we're talking about health equity, it reminds us and demands that we think about the fact that everyone is not starting at the same place, even if we have the same endpoint goal to get to, in this case, optimal health. And that means we have to use our resources in a different way and distribute those in a different way in order to get everyone to that same endpoint. It involves us learning and understanding what community need is and learning from the community, not on their behalf or teaching the community things that they already know, but it really involves understanding what's happening at the community level and going beyond that understanding and moving things into action to dismantle the barriers that exist to getting the resources. The key thing that I want to highlight in this image is that on the left, you see a fence, and on the right, you see a fence. And that fence represents the barriers that are put up, man-made, developed, and furthered by our own hands and our own doing in our society. I often try to remind everybody that racism, the impacts of it, health inequity, health disparities, and health differences in outcomes and care and delivery of care are not things that were made in the spiritual realm. No matter who you believe in or how you believe we came to be here, when we talk about health equity, these are all man-made issues. Health inequities and disparities are man-made issues and barriers that we have put up, just like a fence is built by the hands of man. And by man, I mean human, not a gendered person. And thus, that means we have the power and the tools within us to dismantle those barriers. But what we've become to understand about those barriers is the conversation around the social determinants of health. We've come to understand that what is happening and impacting our health. I'm hearing an echo. Okay. What we've come to understand is that what's driving the health disparities we see in these differences in outcomes are things that are happening not only within the clinical setting, but by and large, things that are happening outside of the clinical setting. And this is demanding us to look at the social determinants of health. Now, I'm going to say a controversial statement in a few moments. I always like to preempt, and let people know that the controversy is coming, but it's not coming just yet. It's coming in a moment. But the social determinants of health are the conditions that we are born into, that we grow up in, that we live within currently, that we work and where we age and ultimately die, that are shaping our health experience. And these are things that are linked to the distribution of money, the power that exists. And this is the definition of power that is not shared power, but rather power that is either hampered or power that is given, and resources that are distributed. And this happens at a global, national, and local level. So when we think about this, health is we are all experiencing health in the context of these United States, but even more so, we're experiencing it within the state lines of Connecticut, and even lower at the local level, we're looking at New London County and New London, specifically even the city. And what we're understanding, even through all of the data that Fawati provided to us at the beginning, is that each and every one of us are not experiencing the same health outcomes, the same determinants of health in the exact same way, that there are a lot of impacts and things that are driving into that. And the image that is here shows you the domains of health, of the social determinants of health. There's economic stability issues, there are education issues, there's health and health care that is driving what we are experiencing related to the social determinants of health, the neighborhood and the built environment, where we live, what we have access to, and ultimately the social and community context. Now, this image, the first image that I just showed you, came from Healthy People 2020. This image from the Kaiser Family Foundation deepens the understanding of each of those domains and goes even further, and of course spreads them out a little bit differently, but goes a little further in understanding some of the aspects that are underneath each of those headings. And what I love to point out about this is that right at the bottom, you see health outcomes. And so what this is saying is all of these things sit on top of our ability to live, our life expectancy, how much healthcare costs us and how much we cost in the healthcare system, our ultimate health status, and our functional limitations. Now, I want to pause for a second and walk through a personal story about the social determinants of health, because I think it's important to share why and how I come to this space. I am a race scholar first and foremost, who has decided that public policy and social policy specifically is the route to how we dismantle racism and its impact in our society. But I come to that from the experience of myself, my health, and my family. It's really nice to sit here tonight, and I'm a little conversational this evening in a vulnerable sharing space. So I hope that this is a brave and welcoming space for that opportunity. But I come to you as somebody who usually doesn't like to hear or talk about my educational background, not because I'm ashamed of it. In fact, I'm very proud to be one of the first individuals in my family to have a PhD. But it's one of the reasons why it's the last thing I talk about rather than the first is because it's so remotely far from my lived experience as a child and for the majority of my rearing and upbringing. I grew up in a home that was made for me and supported for me by a single parent mother. Even though I always knew my father was always in my life. He did not financially provide for us as I was growing up, but he was always a constant person in my life and a good influencer and shape of who I am. But the financial responsibility of my life led on the hands and shoulders of my mother. Now, what we know in general statistics when we look at things is that women make less money than men generally, and Black women specifically make less money than other women, including white women and other men particularly. So you can gather to know that you can take that and extrapolate that data on high and imagine that my mother, a single woman raising a child in the South, was a low-income individual who never made more than $21,000 at the time of her death at the age of 48 years old, never made more than $21,000. So when we look at the economic stability, my mother had to rely on a combination of public programs in order to provide for our household. Thus, I am a person who grew up on Medicaid. I'm a person who knew what SNAP was when it was food stamps, who understood what it meant to stand in line to get government cheese and commodities in order to provide for a meal on your table. I'm a person who grew up in low-income housing, understood Section 8, and can really talk to you from the back of my hand about what a voucher is versus not having a voucher, and what the good neighborhoods are to live in, and how you use that system to provide for your family, and any other social program that you can imagine that led into my home to make us whole and to make us be able to survive. Now, my mother, if I skip over for a moment the neighborhood and connect to the education, my mother had a high school education, and I love to tell you all, she did not pass on to me her math wizardry. She was an amazing math artist. Never went to college. You could give her any sort of equation, she would figure it out really easy. Unfortunately, that is not a gene that I received, sadly, from her. But she did have to utilize public programs that gave her the opportunity to get a career path. And so my mother became a certified nursing assistant because at some point during the welfare reform era in the 80s, they offered an opportunity to get to do public workforce programs to gain the education that you could and the expertise that you could to get a career. And that's the career my mother had until she passed. But even acknowledging that my mother had a high school diploma, it's important to understand that I was the first born and raised in Hampton, Virginia. My mother was from the segregated South in North Carolina. And so education was not equal. So there were some challenges in terms of literacy issues. There were some language differences in terms of how one spoke and understanding what English was, et cetera, or how to use the King's or Queen's English, whichever you want to say. All of these things really were impacted in how I grew up. But my mother really made sure that I had early childhood educational opportunities that led me to being able to be successful. So despite living in a low-income neighborhood where we had to rely on public programs, my mother did her best to make sure that I had the best and most greatest education. So if you notice what I'm doing, I'm walking through these domains to try to give you a little bit of a background of how all of this comes into play about my health and who I am. And even having the greatest education, what my mother could not accommodate for or could not even imagine would happen was an inability to diagnose asthma. We were on Medicaid, and it took us multiple doctor visits and over and over again being told that I had chronic bronchitis until we found somebody who paid for us to get a second opinion, because Medicaid at the time would not pay for a second opinion. And I was finally diagnosed with asthma. So this was actually creating some challenges in my educational abilities. I couldn't breathe. I was in class. They always wanted you to run and do recess. I hated it. My teachers couldn't understand why. It's because I couldn't breathe. And even if I did go outside and play, I would come back in and I would be lethargic and couldn't focus. All of these things were hampering my educational process. It didn't stop me though, because as you can see, I've gone on and have all these degrees and I'm doing all these great things, and that's amazing. But the reason I'm walking you through this is because if I didn't tell you that story, if I don't tell my physicians that story, if I don't connect in understanding and sharing that my grandfather was a sharecropper, once removed from slavery, and understanding the history of African American food and how that grew up in the comfort of my family, and what food looks like for my Southern reared family, what you would present and see is this woman who's from West Hartford, solidly middle class, who has 2 Whole Foods accessible and 3 other grocery stores, and should be the picture perfect of health, but you're connecting to my now and not my history. And so what's important of understanding when we're talking about the social determinants of health, it allows us to understand the historical and contemporary context within which people show up. It's not just where I live now, it's where I grew up. It's who my family was. It's the things that we had access to then that I now have to think through now. And I have to tell you, there were days when we didn't have enough food or the right food or all the different things that they linger into who I am today, where when I am starving and I haven't created a plan. So I've really committed to not using the word starving, because a person who has privilege should never starve. And I am never starving, to be very clear. But when I am hungry and haven't had a plan and I need to make a plan, it's always a challenge to not revert back to the habits that I had when I grew up and come forward to who I have and what I have access to today. All of these things in terms of the historical context weigh into my mortality, my morbidity, who I am. And you can all imagine, even as I just shared this story with you, this is not the information that's being extracted in the clinical setting. At best, when we go into the doctor, it asks us about our physical history from ourselves and our family. Does anyone in your family have a history of cancer? Does anyone in your family have a history of heart disease or diabetes? That's not asking the question, does anyone in your family have a history of being low income or in a redlined community or having had less food on the table than necessary or having moments where they were hungry? These are important questions that we're learning are really, really critical because we now understand and know that only 20% of our health outcomes are driven by what's happening in the clinical setting, but more than 60% of them are really driven by these social factors that are happening outside of those four walls. Okay, I've went on a little bit too long. Makita, you're going to have to probably give me the axe, but I'll try to go a little bit quicker for the rest of it. So you'll remember when I said this is social determinants of health are really giving us an opportunity to say we are not all starting at the same place, but why? And here's the controversy that I promised you was coming. What I espouse is that the social determinants of health are giving us an opportunity to talk about structural racism and racism when we are not comfortable to do so. And at the same time, if we don't push ourselves to really coming forward with an anti-racist lens and understanding the impact of racism on how we get to these social determinants of health, we will continue to only deal with the band-aid of the image, of the issue, meaning people don't have sustainable housing, or they don't have available for fresh food, and not getting to the root of why that happened, that we are not creating housing for people in a sustainable manner in places that they can, and we're not offering and building structures and systems that give people fresh food and vegetables and things that they need when they want them on demand. So this again is said differently. Structural racism is the underlying barrier of why we have social determinants of health issues, and it's allowing us to talk about those things now in ways that we couldn't. Structural racism is a system that structures opportunity and assigns value. And now we're able to use our language in this frame of the social determinants to push ourselves further into this conversation. Now, I'm not going to go through this whole thing, but I want to just take a second because even though I know Jen started at the beginning saying that you're intentional about having this racism frame and really understanding its impact, I just want to quickly make clear how we can make subtle changes in our frame to solutions and how we frame solutions to these issues to ensure that we are really taking note of how racism impacts the issues that we're seeing today. So quickly, the Gardener's Tale. I'm not going to tell the full story. It is not my story. Dr. Kamara Jones is the author of this. If you've not read this allegory, it is an amazing way of understanding all of the levels and forms of racism. I highly encourage it. We can drop a link in the chat if you haven't seen it before. But really quickly, Dr. Jones tells this story about being a gardener and how she inherited two flower boxes when she got this beautiful home in Baltimore. One had rocky soil, one had fertile soil. I'm doing a short change of this story for those who've heard it before, just so that we can get to the to the heart of the matter here. In the rocky soil that wasn't so fertile, there were pink flowers that were put there, the exact same flowers as the red, the difference were the colors. And in the more supple, rich soil, the red flowers were put into that soil. Time goes on. Every year they bloom and blossom. The red flowers are gorgeous. They're beautiful. They're getting to their fullest potential, their highest height, and they're lovely. And the gardener finds herself really loving these red flowers. Red was already a preference for her. She liked red in the beginning, but she found herself really digging these flowers because they're really beautiful. The picture of what she imagined the flowers would be and become. But the pink flowers, over and over and over again, year after year, they're not doing as well. They're not getting to their full potential. They're not growing as tall as the red flowers. Some of them, as time goes on each year annually, they're dying off a little bit more. So you're not getting as big of I was about to say crop. I've been talking about farming with my family. You're not getting as big a production of flowers as you would each year. And she finds herself not really being excited about the pink flowers. Now, what we're talking about here in this allegory is the how we systematize difference, and how those differences create different solutions. Excuse me, those differences create different problems and different issues in which we can then come up with solutions. So let's walk through a couple. So we have the red flowers and the pink flowers, and we could do nothing at all. Like, we don't need to change a thing. Let the pink flowers grow like they're growing, the red flowers grow like they're growing. We can continue to have a preference for the red flowers and think that's right. And ultimately, what that does is it reinforces the status quo. The red flowers will continue to prevail. Nothing changes for the pink. And our attitudes and behavior towards the pink may change, thinking that there's something wrong with the pink, and we may continue to love the red, but ultimately we've done nothing to change the problem, because maybe we don't see that there is a problem. But let's say we acknowledge that there is a problem and we think something's a little bit off here and we should probably do something and engage. One of the things we could do is we could change the soil and give both the flowers the same thing. So that rich, supple soil that the red flowers were growing in, we could say, hey, that seems to be working for the red flowers. Let's just take the pink flowers out of the soil they're in, put them in that supple soil, and go. This should be the answer to fix it, right? Well, if I have any gardeners on the line, and I think I do, because it's called the Fresh, this is Fresh New London. So I think some of you know how this goes. If you do that, the pink flowers have already spent a lot of their existence in that rocky soil. So they're still never going to get to that full potential of the red flowers. And remember, they're the exact same flower. Even though my images showed you different flowers, they're the exact same flower. So we should feasibly think that they could get to the same outcome. But ultimately, these pink flowers have spent most of their existence in that rocky soil already. Another solution that we could come to is we could acknowledge that there were differences. The pink had the rocky soil, the red had the fertile soil, and we could accommodate for the fact that what we really want to do is get that pink to its best opportunity. Like, what is the best outcome we could experience for that pink, given where it started? And we could then distribute our resources well. This is what my gardeners know, is that we would turn that soil over slowly and always keep some of that rocky soil in there, because that's what they had from the beginning, but continue to provide them with that rich nutrient soil and giving them more nutrients into them to give them the opportunity to grow better. Here, the pink and the red flowers have different needs, and that's what we're acknowledging. And to get them to their optimal growth, we have to do something different. This entire framework is helping us to understand this. If we took this out of thinking of gardening and talk about the structure of racism, it acknowledges that people who are racially minoritized in the United States, and particularly in Connecticut, have not always had the same things as people who are not racially minoritized. This means that we have to acknowledge that we can't do things like say, we can just move you to somewhere else and your opportunity is going to be better and your life is going to be awesome and it's going to be so great. It says that we have to recognize we must bake in, one, equity into the process, but we have to also acknowledge the system that got us to this outcome. Well, how did we get here? Ultimately, we have to acknowledge that racism is the factor of how we got here. We're not all starting at the same place, so what do we do about it? One thing that we are imploring as an organization and hoping that others are, and I heard Jen say it at the beginning, is we need to unapologetically, loudly, and often call out racism. We have to intentionally be anti-racist. Now, for some people, that's uncomfortable. And remember, I said at the beginning, my job is always to try to make people a little bit uncomfortable. Ultimately, we've been arguing that we need to declare racism the public health issue that it is, so that we can, okay, sorry, I was trying to read something in the chat. We have to declare racism the public health issue that it is and name it, and so that we can begin to dismantle it, because we, as the humans who are living and existing within it, we didn't create it. We are far from the ones who created it, but we have all the tools we need to dismantle it once we acknowledge it and acknowledge its impact in our life. I'm going to skip over this because there are forms of racism and I'm running out of time. And I want to get here to this image because I think this is super important and hyper contextual to New London. A part in the first step of acknowledging that you have a problem is acknowledging it and naming it and then moving into action around it. And I think these two things are really, really important. You cannot just name it and say, okay, racism, thanks everybody, and then disappear and do nothing about it. We have to simultaneously acknowledge the system that racism is, that any system produces the outcomes that it is designed to produce, and that we must dismantle it. This requires two things simultaneously. It requires us to have a long-term goal towards liberation, where when you go back to the equality and equity images that I showed earlier, that fence is dismantled and gone, and that we don't have to give people additional resources to get them to the best outcome because we've already provided everything they needed at the beginning. So that means addressing every one of those social determinant domains to ensure that it is not a determinant of health. I'm going to pause and let that sink in. Addressing each one of those domains to make sure that it is not a determinant of health, because we've built a system where everyone has what they need, because we know what it looks like to have those be the drivers. And at the same time, because that's a big long-term vision and goal, we take the wins that we can along the way that get us towards equity in the meantime that we're trying to work towards liberation. So what this map is showing you is that first step. We created a petition, we asked people to sign on, and we asked people to acknowledge racism is in our policymaking, it is in our decision making, it is happening every single day, it is active, it is silent, it is here, and we want to dismantle it, and we know we have the tools to do it. The second part of this map, and that's all of the purple, so that's where everyone signed in from who signed the petition. The second part was declaring racism a public health crisis. I'm happy to say that 20 Connecticut cities and towns have done this so far. There are another dozen who are in some other part of where they're either in the declaration part or they actively said they're not, but they're thinking of other parts. New London is on this list. Thank you to everyone who participated in that activity. I'm also excited that we have the first tribal nation in the history, in the nation to do this, and that's the Mashantucket Tribal Nation. And together, I argue, we can dismantle the link and the chains of racism within our society. I'm going to stop there and stop my share because I know I think I ran completely over time, and I apologize. I got kind of into it and the chat was hidden. So I should have just said, give me the verbal acts, but I'm going to be around for questions. But thank you, Fresh, for the opportunity. Thank you, Makita, and thank you, Jen and Stephanie, and I look forward to the discussion.